today we're trying something different. We're doing a live podcast, and we're just going to go through like all the posts. We put some posts out about questions you might have and topics you wanted to cover. So we thought we could do a little more in depth. We'll put this out, video and podcast out after, but we wanted to do this somewhat of a regular thing of answering viewers' questions and just doing like Q&A ones.
Yeah. So if you have specific questions, just fire them in. We'll try to answer them as we go along.
Yeah. So, and I've got a bunch of these pulled up, but we'll also answer some of your guys' questions live. So if we don't see them right away in the chat, sorry about that. Feel free to put questions in there. But we had a post last week, and there's a lot of people put questions in there. So we're going to start with some of those. So I think one thing to start would be, and I think people would wonder this a lot, is just like a typical day in your life as a neurosurgeon. Well, a lot of people think of like doing the surgeries. Like, what time do you get up at? Like, what's your routine look like? Do you want to just walk through that?
Yeah. So just pick a day. Like last week, I had a day where I had 3 surgeries, and basically, I don't know. Surgery starts at 7:30. They take the patient back to the operating room at 7:30, but I always try to be there half an hour early. I didn't have any patients in the hospital, so if I would have had patients in the hospital, I'd get there even earlier. But I get up usually around 5:30, I think, and then maybe sometimes if I don't have to be there till 7, I might get up at 6 o'clock, and I get up and I go. Obviously, if I have to take a shower, brush my teeth, things like that, get ready, get dressed. Then I go downstairs and I typically I make a lunch, so I pack my lunch and put some snacks in and things like that, and I get that ready. If the dogs need water and the watering thing, I'll put some water in there. And then what else will I do?
What time do you usually?
I make some coffee, obviously coffee to go, and then I sit down. I usually sit down for 5 or 10 minutes. Yeah, by the heater, like 10 or 15 minutes, just to relax. And I just kind of close my eyes and just sit there, and not really necessarily meditating, maybe in a way, but I just like to clear my mind. It just just settles the day, and then I go.
So what time? I know. So sometimes you're sitting down there in the dark at like 5:30 or 6. What time do you usually leave at? Do you think like 6?
No, I mean it depends. So it just depends. I mean, like if I only have to go to surgery and I have patients in the hospital, I may only leave at 6:30, 6:45. If I've got patients at different hospitals and I'm on call and I got to see consults, I may leave at 5 o'clock or 5:30 in the morning to get that done before surgery. So it really depends where I have patients at what hospitals, how early my surgery starts or my office starts and things like that. So it's just a general idea, but it's early.
Yeah. So you usually start like your first surgery usually starts around like 7 though, right? So
my first surgery usually starts at 7:30.
Oh, 7:30. So then you base it off that, like getting there at 7:30 if you have other stuff to do before then.
And then I usually kind of break it down in my head. Like if it's 7:30 start time, I usually make incision on the patient like 8 o'clock. And then my first, one of my days in the last couple of weeks, I had a big fusion surgery. So that was like a 3.5 hour surgery. So I start at 8, finish around 11:30. And then it takes an hour to wake up the patient for them to clean the room and then get the next patient in. Usually it's a little bit more than an hour. So maybe I start the next case around 1 o'clock. Next case was a neck fusion from the front. Takes about an hour and 15 minutes, hour and a half to do that surgery. So what does that put you at? What do we say, 11:30, 1 o'clock? So that puts me about 2:30. And then they have to wake the patient up, turn the room over, maybe start that case around 4. And then the last surgery was a person with a pinched spinal cord. So I did surgery from the back of the neck to unpinch the spinal cord. That was like an hour and 15-minute surgery. And then when I'm done with that, I think I had one patient up on the floor to go see a consult I had that I went and did. And then I go home, and I think I got home around, 6:30 or something.
It just varies a lot by day.
It always varies. It depends if you're on call and how many consults you have when you get out of surgery and how many patients you have. And anybody have any problems, you have to go see them again. So,
So this is a good one going off of surgery. So equipment and products needed to complete a case. Like obviously it varies by surgery. What is some of your most common tools you use?
Yeah, so they have kits that's in the hospital. So if I'm going to do a lower back surgery, just like a lower back surgery without fusion, they'll have like 3 or 4 trays of standard instruments that I use. and they're for me. So it's Dr. Hoeflinger's trays. So I have specific things in there I like, and a different surgeon may have something else. But those trays are made up, and then they open those trays, and then there's all kind of different things you use. I mean, I can name them. It won't make sense to you, but like a Penfield 4 instrument, or a handheld retractor, or bipolar instrument, or Metzenbaum scissors. So all the things that are 11 blade. But
so why don't you just like maybe pick like two and just describe what you would use them for? Like,
describe what? I mean, the instruments are hard to describe. I mean,
no, like what you would use, like what's the case for? Like
yeah, so like a bipolar instrument is just a general instrument. It comes for most surgery. So, if you get into bleeding, you have to cauterize a blood vessel. A bipolar instrument has little tips that a current goes between, and when you touch those tips on the structure, it burns the structure in between. So it cauterizes it. So a bipolar instrument I use to cauterize things. A Penfield 4 instrument is like a little spatula. It's very small, looks like a miniature spoon. But when I need to gently move the nerve over or dissect tissue from a nerve, I use that instrument. I have a hand.
What's the one tool like when you have to like take part of the spine bone out or the bone out? That like bone crunching tool?
Yeah, so there's different. There's a Lexel rongeur. A Lexel rongeur is a bone instrument that bites the bone away, big chunks of bone. So that's an instrument. Drills, we use a drill a lot. So sometimes I drill bone away. It gets really hard. Some people's bone is very thick and hard, and it actually hurts your hands to try to bite this bone away with instruments. So often I'll use a drill to thin that bone down, and then I can use the other instrument to bite the thinner bone off. So there's a lot of different instruments that we use, and you have to tailor it to what you're doing, where you are in the body. Obviously, stuff that you use on brain surgery, on the actual brain, is different than things that we use in spine surgery.
Someone wanted to know: Do you use any Olympus medical products?
I do not use Olympus now.
And then is foot drop common when having a fusion or an L4 L5 fusion?
It's not common. I mean, obviously, the nerves that we're working around control the strength to the foot, and if someone has an injury to a nerve, they can end up with a foot drop. Or if someone has a diabetic neuropathy, that's a condition that can cause a foot drop. There's a nerve on the outside of the knee that controls lifting the foot up. If that get injured, people can have foot drop. So it's not usual during that surgery to have a foot drop. Most of the time people have foot drop before they have the surgery done, and then you do the surgery to try to help with the foot drop.
So when getting the laminectomy, what would be a reason it would affect the SI joint? Or is there a specific reason or not really?
Yeah. I mean, these are all my opinions, honestly. I don't know. SI joint is a different structure from where we do a laminectomy over the back of the spine. So I don't know of a correlation necessarily between the two structures that I know of. So I don't know as if a laminectomy would cause a problem with your SI joint that I know of, but that's just my opinion. I don't know. Maybe somebody else knows something I don't.
What about, so if say there's a blood clot in the brain, what would be like the process of removing it?
Right. So you have a blood, so say you're in a car accident, somebody's in a car accident and they hit their head and they hit maybe crack their skull or something along that line. A blood clot can form over the brain. And so that can become an emergency because people die when those blood clots get big enough. So what you do at surgery, say it's on the right side of the brain, you have to shave, you position the patient on the operating table with their head like this, and then you have to shave most of the hair off of that side of the scalp. You make an incision in the scalp and reflect the scalp back, so you're looking at the bone. If your muscle is there too, you have to reflect part of the muscle too. Once you're looking at the bone itself over the skull, you have to make sure, obviously, that the bone you're going to take off is over where the blood clot is. So that just comes with experience. And then we have a little drill called a Codman perforator, and it's a drill that will drill holes through the skull. And so I drill a perimeter of several holes where I want to take the bone off. And then we have an instrument. It's almost like a buzz saw, and it has a foot plate that fits under the bone but above the brain, and it's power, and you pull it you connect the holes, and then that completes what's called the craniotomy. and you lift that piece of bone right off. It's one piece of bone that comes off, and we save that bone. And then you're looking at the covering of the brain. If the blood clot's on the outside of the covering of the brain, you'll take the blood out right away. That's called an epidural hematoma. If the blood is under the covering of the brain, you have to cut open the covering of the brain and reflect that back, and then the blood will be sitting there over the brain, and then usually you gently irrigate and have a couple instruments to take that blood off the top of the brain. And so that's how you take a blood clot off the top of the brain. And then if there's active bleeding, you have to stop it. Sometimes when you take the blood clot off, there's bleeding from the brain. So that's where you use those bipolar instruments to stop the bleeding. Once that's all done, if the brain isn't too swollen, then you can close the covering of the brain, put the bone back on with little plates and screws, and then sew the muscle and the scalp back together. If the brain is swelling so bad that you can't get the bone back on, so often we'll leave the bone off and let the brain swell over the ensuing weeks, so the patient will survive.
Do you eat breakfast before surgery?
Yeah, most of the time I don't. I'm just not hungry that early in the morning, so I usually eat when I get done with my first surgery. So sometimes it's 11:30, noon when I eat. Sometimes if it's a shorter surgery, I'll eat around 9:30 or 10. I've done that my whole career.
Is there any aspect of surgery that grosses you out?
No, not anymore. But sometimes like a bad infection somewhere in the brain or the spine. I mean, it can really, when the pus comes out, it can be pretty gross looking, but it doesn't, not much affects you as far as grossness anymore, I don't think.
I don't know for this one because it's kind of hard. I don't think there really is anything. But for like migraines and headaches, do you have any thoughts on that of what the causes or anything like that?
I don't treat migraine headaches. That's what a neurologist would do. So often if someone has a migraine, what I think is a migraine headache is their problem and not something that is structural that I can help with, I would refer them to neurologists for that. So I don't deal much with migraine headaches. There's so many different reasons for migraine headaches, and doesn't have to be from a brain tumor or some other problem like that. So,
yeah. Intracranial pressure.
Right. So intracranial pressure is just the pressure inside your skull. You can measure that. You know, if someone comes in with a bad head injury and they're in a coma, and say they don't have a blood clot, I mean they don't have something that needs surgery, but you're worried about increased pressure on the brain, we drill a little hole through the skull and put a little fiber optic monitor wire into the brain, and that will monitor the pressure, and we can see how high the pressure is. So intracranial pressure is pressure inside of the skull that puts pressure on the brain.
Degenerative disc disease, like what it is, and
so degenerative disc disease, it's more of a it's something you can see on an MRI, so it's more of a radiologic finding, but it is degeneration of the disc. So it's not a disease, it's a condition. So as we get older, our disc will start to degenerate. So they lose their water content, and they start showing up as dark on an MRI. So when you see a dark disc on your MRI of your back or your spine, that's what we call a degenerated disc. Degenerated discs themselves, sometimes it causes pain, sometimes it doesn't. So not everybody who has a degenerated disc will have chronic back pain, but if you have one level of degenerated disc and the disc is collapsed, often that can be the reason for your back pain. And you can treat that with conservative measures, or sometimes people need surgery to have their spine fused at that level. But degenerative disc disease is not a disease, it's a condition of the spine where the disc is aging and it's losing its water content.
A lot of people ask about like trigeminal neuralgia. I don't know if you want to touch on that just a little bit.
So trigeminal neuralgia, it's a long-standing, it's been in the history books for a long time, but it's one of the most painful conditions as described by people that you can ever have. And it's lancinating, shooting pain into the face. It can be, the trigeminal nerve comes out of the brain and it goes into your face. There's three sections to it. There's V1, V2, and V3, and it covers the forehead, the cheek, and the jaw area. And so those nerves can send horrible pain, just incapacitating pain into the face, and it comes in waves. It's spasmodic. Some people have committed suicide because the pain is that bad. So it's a condition of the trigeminal nerve, which is one of the cranial nerves in your brain. The treatment for it varies. I mean, the first line of treatment for trigeminal neuralgia is medication. So there's different medications that you can use to treat it. Sometimes people have to be on 2 or 3 different medications to try to stop the attacks of pain. if medications don't work or cease to work, then there are other procedures you can have done. There is a procedure where you can put a needle and then a balloon over the nerve itself and inflate the balloon and compress the nerve. And that can help for months or years with the pain for most people. There's a procedure where they do a RF rhizotomy where they actually burn the nerve. That can help. Those tend to be more temporary procedures. They don't last forever. They have to be repeated in most people. And then there's a bigger surgery called a microvascular decompression, where it's a regular craniotomy where you have to take the bone off the skull, dissect down in the brain to where the nerve comes out of the brainstem. And often what people find, there's a blood vessel usually over the nerve that's stimulating the nerve and causing the trigeminal neuralgia pain. And so there's a little piece of gauze, at least when I was doing these procedures, a little piece of gauze that we would put between the artery and the nerve, or the blood vessel in the nerve, and that usually would cure people long-term of their pain. So there's different ways to treat the pain, from conservative to more aggressive ways. Most people can be treated to some extent. There are people who, unfortunately, their pain is not well controlled, but it's a horrible pain that's well documented in literature. It's been around for a long time, and it gets so bad that a lot of people have committed suicide because of that type of pain. So the people who have trigeminal neuralgia know what I'm talking about. And
how often have you? It's a pretty rare disease, right?
Yeah, it's not that common, but for people who treat it, I don't treat trigeminal neuralgia anymore. But when I did, people get referred to you, so it can seem common to you because all those people get referred to you. But it's a pretty rare.
From a primary, or they've gone to
it could be a primary doctor that refers them. It could be somebody in the a neurologist that saw a person for trigeminal neuralgia and refers them to a surgeon. It could be. It could be any doctor. You saw an orthopedic doctor and he realized that you had trigeminal neuralgia. Dentists will be, people go to the dentist because they're having pain in their gums and their teeth and they think it's a dental problem, and the dentist will diagnose.
Okay. Do you think people with physical jobs have more back injuries with neurological involvement than other occupations, or have you seen that, or what do you have any opinion?
I mean, certainly a lot of people that see me will say I was doing this for a long time, or this type of work, or had this happen at work and now I have back pain. So I don't know the literature, honestly, to be honest, if there's a direct correlation. I mean, obviously if it's a traumatic incident at work that you get a blunt trauma to your back, that certainly can be the cause. But is a job where you're stocking things or repetitively lifting, is that something that causes chronic back pain? I mean, some people it is, but some people do that their whole life and they don't have a lot of back pain. So I don't think there's a good answer to that. I mean,
there's probably a lot of compounding variables, like if you're lifting properly,
right.
if you're strength training your back,
how much you're lifting, how frequently. I mean, there's just so many. And then there's genetics. I mean, there's got to be a big genetic component to back pain. And so some people, maybe they have a genetic predisposition to back pain, and then they have a hard job and it's back breaking. They're probably a setup for back pain, so.
And
it's
also
tough question
as your body gets older, like no matter what, you can't beat father time.
Well, because then the arthritis sets into your spine and your joints, and the discs start to degenerate, and that that's why we get aches and pains in our joints and our body as we get older, just because of those reasons. So,
yeah. Do you think there's a part of surgery that's the most interesting to you, or what's the most interesting surgery you've been involved in?
I think the most interesting procedures are things that are more rare. I saw more of these things in residency where something that doesn't come along very often, or certain procedures. Like there was a procedure in residency where we would take half the brain out, I think for Rasmussen's encephalitis, and tumors deep in the brain where you rarely see that anatomy, only on rare occasion when you're deep in someone's brain. So, but I think brain procedures are more interesting. Brain tumors and things like that are probably more interesting than spine. But it's pretty neat to see the spinal cord and the individual nerves, which I see every day too.
Do you ever get nervous or anxious before or after surgery?
No. I mean, I don't get nervous per se. I just always am cognizant that when I do surgery on somebody, I want them to come out exactly the same or better. And so I want to make sure when I do surgery on somebody that I'm very careful. And so that's what I think about most of all is, as I'm doing surgery, I'm thinking of the steps, thinking ahead, making sure, that I'm doing what the patient needs to have done, but not anymore. I always worry. I want to make sure that people, come out of surgery the same with no deficits, and hopefully their pain is better. So that's what I think about more. But it's not actually nervous. It's about trying to protect the patient, I guess, which I guess could make you apprehensive.
Have you ever done surgery on someone with brain parasites?
With brain parasites? I don't know if we did, and I don't think I have.
What causes your spine to fuse naturally?
Yeah, I don't think there are certain conditions, I guess, that people can have, like ankylosing spondylitis. I think is a condition that can cause that, but it would have to be a certain, probably genetic condition that causes premature fusion. Now, if somebody has a spine infection, like say you get an infection, like what's called an osteomyelitis or a discitis infection of the disc or bone, when that's cured and treated with antibiotics, I mean, that causes the bone to grow and fuse. So there are certain conditions like infections that can cause fusing of the spine prematurely. And then sometimes people just have congenital or genetic conditions where their spine fuses. They have a condition that predisposes them to it.
Yeah. Where did this one go? When do you start leading surgeries in residency?
When you start leading? So in my residency, so even when I was a first year neurosurgery resident, we would be in surgery assisting right with the surgeon. But I would say when you start leading surgeries is more later years, like your 5th or 6th year, especially when you're chief resident, you're the primary surgeon. Your attending is there, but you do the majority of the case. Probably, that's probably the most surgeries you'll do in a year, I think, is during chief residency because we're operating every day on complex big cases. But that's when you're the lead surgeon as a resident would be chief resident. Any live questions?
Yeah, some of these are.
Okay.
Some of these are
okay.
Live questions. Like last couple of them. How cool is it growing up with a neurosurgeon father? Pretty cool. When I was much younger, I didn't really understand what he did, but as I got older, it was cool to understand.
What's cool about it?
I mean, there's a lot of things. Well, it's cool to see what people perceive neurosurgeons do versus what's actually done. I think some people just think, a lot of times they don't realize that they think that you're just a brain surgeon and you only operate on the brain. Mm-hmm. Even a lot of people I meet now, and there's just a lot of things like you put, people talk about like in books in pop culture, like about what Navy SEALs, fighter pilots, brain surgeons, you know what I'm saying? So they talk about people who can focus and do stuff like that. So that's cool. But it's also way different. If you don't, like, there's not a ton of neurosurgeons. So if you haven't met someone who is one of these things, for other people, they just think you're like a robot, versus until they know a person, they might think you're like someone who wouldn't like know you if they just heard about you before we started making videos, might just think you're a lot more serious or a lot more, intimidating. Like a lot of people are intimidated by you, I think, before they meet you, just because they know you're that you're a neurosurgeon. Then once they meet you, they know you're just like a regular guy.
Yeah. Well, see, I think there's so few there's like 3,500, 4,000 neurosurgeons in the country, but in Toledo, how many neurosurgeons in Toledo? I think there's there's probably 10 or 12. I don't know, 10. But there's not many for a big city.
Yeah. No, I think most people just don't meet, someone. I mean, obviously, like that's what's funny when you go to like the conferences. There's all these neurosurgeons in one place, but most of those people. So you are much more likely as a doctor to see neurosurgeons and other surgeons, but for the majority of people, they never
meet somebody like that.
Let's see. Yeah. So what else? What do you think are the most common things like when you've met people in your life since you've been practicing neurosurgeon the last 24 years? When you meet someone and you say you're a neurosurgeon, what do you think? Like misconceptions or?
I don't know. I don't know what people think because they don't really say anything to me. Like people just say hi. I don't know I don't know what they're thinking. They don't really go like wow or anything. Most people like I'll be somewhere and someone will ask me like we'll be talking and they'll say what do you do? And I'll say I'm a surgeon. They'll go, what type? And I'll say a neurosurgeon. And then that kind of ends the conversation. Like people they don't ask me many questions about it. Like we move on. I don't know if they're intimidated or they don't want to look stupid and ask questions. So have you noticed that? And people don't really ask me much about
Yeah, no,
Even my friends, like they don't really ask me like what goes on in the operating room. I don't know. People that are squeamish about asking me what I do because I don't know. They're either not interested or they're scared to ask.
well, that's what's weird because like so many people are interested, I think, but it's just they think they're not going to understand anything. Maybe I think that's why some people like the videos because when you break stuff down, someone who really understands the topic can break stuff down so uh, anyone can understand it. Just like someone like Stephen Hawking or Albert Einstein, like those people could break down super complex physics and make it in the way a typical person can understand. So I think a lot of people, like you said, live with different things, people don't want to ask, or they just don't even know what to ask. They don't even know about some stuff. What about Chiari malformation? Do you ever see that?
So Chiari malformation, it's one of those things that I think is overdiagnosed. There's a part of your brain in the back called the cerebellum, and the bottom of our skull is called the foramen magnum. It's like a circle area where the brain meets the spinal cord, and so there's this tissue, the cerebellum tissue. If it drops below that level of the foramen magnum, below the level of the skull, then that is called a Chiari malformation. I think you can have 2 or 3 millimeters below that level is okay, but if you're past that level radiologically, they call it Chiari malformation. So true Chiari malformation can cause headaches. It can cause headaches back here. It can cause weakness of your hands, drooling, trouble walking, and that's because it's pressing on the brainstem and the upper spinal cord. But most Chiaris that I see are just, they're 3 or 4 millimeters below what's called the foramen magnum, like I described. And so they get sent for surgical consultation. And most Chiari malformations, in my experience, don't need surgery. Most of the time, headaches I do not think are due to Chiari malformation. But I've had a few people, obviously who've had very large Chiari malformations. I had one gal who was dropping things with her hands and her balance was off and she couldn't walk and she was weak in her arms and legs. And so I did surgery for her Chiari malformation to open up that space, and she got back to normal strength and activity. But those are the exceptions. There's so many people that get sent to us for just mild Chiari malformations that really I don't think they need surgery. And so Chiari malformation is just a condition. It's diagnosed by looking at an MRI and looking how far that tissue is dipped down. So if anybody has that, you might get referred to a neurosurgeon to have it evaluated, and you just have to talk to the neurosurgeon, see what kind of symptoms you are having, and then you can determine from there if you need to have surgery or not, or would benefit from it. So that's an individual conversation you have to have with your individual neurosurgeon.
Why do orthopedic surgeons operate on spines as well as neurosurgeons?
Yeah, so it's called orthospine surgeons versus neurosurgeons, and so typically in an orthopedic residency, they do a full 5-year orthopedic residency, which deals with all the joints of the body, including some spine, I think. But then typically they'll do a 1 to 2 year fellowship after residency to specialize in spine, to learn spine surgery in detail. As opposed to neurosurgery, in our residencies, we do spine all 6 to 7 years of our residency. So it's just a different way of training. And again, I don't think one's better than the other. There's great orthospine surgeons and there's great neurosurgeons that operate on the spine. So it's individual to the surgeon more than I think if you're orthospine or neurosurgeon. They're both trained.
Were you nervous the first time you did surgery on a live person?
Yeah, I don't even remember when that was, but I'm sure I was.
But also, you'd have to specify the first time you ever did surgery on a live person, you would be a residency, so you had to be
right. You have to involve you, but
or a resident.
I think the biggest thing when you first are operating on your own and no one's in the operating room with you. So, you do all these years of residency where someone's always there to bail you out if you get into trouble. And then you get into out of residency and you're in the operating room by yourself operating a live person is daunting because you're responsible. And no matter what happens in that room, if I get into the bleeding I can't stop or a nerve gets injured or something, I'm the guy that has to take care of it. There's nobody else to bail me out. So it's a learning experience. It's where you really grow up fast when you get out of residency and you get into practice by yourself. You have to stay calm. You can't let things jar you. If something happens in the operating room, you just got to slow down and just work your way through it. You can't give up because you don't have that option to give up. You can't leave the operating room. This is a real person who has to wake up at some point. So yeah, it was nerve wracking in the beginning, but as you go through the years, I'm 25 years into it. most things I can handle now and it doesn't faze me. But when I first started out, there's always that learning curve, like anything in life,
Yeah. Well, don't you think that's why the training is so rigorous?
So long, yeah, because they try to get you used to this stuff before you can get out there, but it's still different. It's like somebody can. Haven't you ever been there where somebody can tell you how to do something, or you can watch somebody do something a million times, but when you are actually doing it, it's like you forget everything. It's like, what do I, it's all new to you when you're actually doing it. You Definitely. Can watch somebody and it looks easy and you watch them, but when that person leaves and then they say, okay, now you do it, it's like all of a sudden you forget. What do? I don't know what's my next step.
It's the different levels of learning. Yeah. So watching someone doing it yourself and then teaching someone else to do it, you progress levels and you shows deeper understanding. So this person asked, do you think neurosurgery is significantly different than 10 years ago? They just asked that live.
Yeah. I don't think it is. This is just my opinion. Other people have other opinions, but I think the basics of neurosurgery has remained the same since I was a resident. Many of the procedures that we did in residency, I'm doing the exact same way I did in private practice. Yeah, there's been advances in navigation, like for brain tumors and doing biopsies. We used to have a very complex, archaic system that we would use, which was very accurate, but it was a big, complex system. Now we just have a wand that we put over the brain. It tells you exactly where you are. So I think it's facilitated accuracy, but it's facilitated getting a procedure done more efficiently, but has it in the end made everything all better? I don't know. I think things are basically done the same, but there's robotics now and a lot of different advances in gene therapy. But I think the basic way of doing surgery is the same as when I trained. You just have different devices that can assist you at different levels, I guess.
Did you ever have to break scrub to use the bathroom?
Surprisingly, my whole life, I've never once broke scrub to use the bathroom. Unless if we're in one of those, 12-hour cases, obviously you have to take turns. You're in there with another surgeon, so you can leave to use the bathroom. But
so individually,
I've never left the operating room. I can say that with complete truth. Never left the operating room to go to the bathroom.
Have you had to, when you guys are both operating, not just the bathroom, but switching, one of you's so thirsty or just because that's kind of long term. If you're doing a really long, just doing a triathlon or something, your body, you can't take in no food, right?
I don't know. For me, my body changes when I'm in surgery because you're focused. I think my body's trained not to need to go pee or anything during surgery because I don't know why. I can be out on a Saturday, drink a bunch of water, and I got to go to the bathroom, multiple times. But when I go to surgery, I just don't. My body's been trained not to make me.
So even if you're doing surgery, have you ever you don't really get thirsty or hungry?
I don't. I don't.
Well, no. So you're just
then that hunger comes when I'm done. It seems like, and if you're in there for a really long case, obviously it's not good to go without drinking. So we would stop periodically and drink, or sometimes the nurses, I can't ever say, I've been in surgery where it's late in the afternoon, I haven't eaten. I'll ask the nurses to bring me some orange juice and crackers. And what they do is I'll step off to the side and they pull my mask up and give me a straw and I'll drink the orange juice and then put the mask back over. Or sometimes I'll break scrub just for a second to drink that or take something and then scrub right back in, but never leave the operating room.
Yeah. How is your back with so much leaning and bending over during surgeries?
Yeah, I've noticed a little bit of change through the years. As I've gotten older, I have a little bit more pain in my back, and especially in my neck. I'm always looking down. I'm surprised I don't sit like this all the time, but it's not bad. I'm surprised it's not worse. Sometimes my hands get achy from using them through all these years, but not as bad. I thought I'd probably be more sore as the years went on, but I'm not.
What about on the topic of being in the operating room? So you stand on a standing pad, right? That standing mat?
Yeah, so sometimes I have a standing mat. I don't even use the standing mat for comfort. It's more for height. It raises me up a little bit to get in focus. But sometimes I don't use a standing mat.
So do your feet, what kind of shoes? You just wear your normal shoes?
Yeah, I just wear loafers. A lot of people have specialized shoes. I've always just worn regular loafer shoes.
You're again, you're probably just so focused, but your legs, do you ever feel your legs really tired after a long standing?
Yeah,
for a long surgery?
I think so sometimes.
Yeah.
It varies. Some days you feel good and other days you don't feel as good, like everybody else.
Yeah, well, no, because for me, I can, if I'm walking a bunch around, I'd rather walk for hours. Standing in one place for a long time, your legs.
Well, you definitely move around. I'll shift from side to side, and stretch my back, if you're in a weird position.
Yeah. So I'm just going to end with a couple light or just lighter ones. Everyone's obviously just asked about all this. And if you guys are just listening or seeing this video, this like live podcast later on, we're going to try to start doing these, maybe every couple weeks, but have this be a regular segment where we do your live questions. You can ask about anything. We look through. Yeah. For anyone live, you can put your comments in, and also we post from time to time. Like we post regularly on social media, and we post specifically about video topics and other things. If you comment those, we look through all those all the time, and we try to curate some good comments.
But real quick, I want to ask something. So you can see we both have these Ironman shirts on. So we were just in Ironman Chattanooga last weekend. Kevin did a Chattanooga Ironman. I just got the shirt. I finished an Ironman in 2017, so I can wear it.
It's capable.
But tell us a little bit about it. What was it like? I haven't asked you much about it.
Yeah, so
it was a hot day.
It was very hot. So started at 7:30, and
what time did you get up?
I got up at 5.
5, okay.
Yeah, so because you went to the start line, dropped my stuff off,
and it was dark, right?
Yeah, it's dark. Yeah, very dark when you get there. But it's crazy. Like there's so many volunteers out there, police officers, and so many people. You get your bike ready and your run bag. You have drop bags for the transition, and then I took a bus over to the swim start, and that lasts like half an hour to an hour. Like when you're just waiting around. Yeah, because we had to take the last bus was like at like 6:30 to 7.
Is it kind of nerve wracking sitting there a little bit?
Yeah, I just try just like with the days before, but I just don't think about it because once it starts, I know you'll just keep going. So I mean, I felt at peace with it. Like, and then at a certain point, I got my wetsuit on, and yeah, once that line's going, you see it's a jump start into the river off the dock. So
it was in the Tennessee River. Yeah, they swam.
Well, yeah. And so 3 people go off at a time. They do a rolling start. So every 5 seconds, 3 people jump in, and so it just beeps, and the line moves forward. So it slowly moves forward. I was about 5 minutes after it officially started, and they do a rolling start for 30 to 40 minutes. But once I was in that water, since I had the wetsuit on, it felt nice because it's not as cold, and if you have to swim without one. And it's quick. We're going downstream. I knew it was going to be a quicker swim because they had talked about you're with the current. But
now I realized just real quick, there's 1,600 people that were in this. I mean, 800 and some men and 400 and some. So I guess it's 1,200 or 1,300. But a lot of people. These are all the people who are getting in this river. I mean,
it's better than when you did it because you didn't do a rolling start of. You got people kicking you and like grabbing your legs sometimes, but it was a lot more spaced out, and it was the river, and you didn't have to specifically go on the left or right side of a buoy. You just had to go down since it was point to point. Most swims are a loop. So I think that it was definitely much better in terms of not getting kicked and all that stuff. Because usually you have to fight for your life. Everyone's just focusing on their own swim. Like if you're not a pretty strong swimmer, it's very daunting for people.
And was it hard to stay straight? You have to lift your head up and see where you're going.
Yeah, I have to sight pretty often. I have more. I always end up dominant going towards my left side if I just without like a line to look at. So I had to look up and I'm like, oh, whatever. I just wasted energy going over here. But yeah, the swim was fast, and that was about 53 minutes.
So then when you got out, so what happens when you get out? So you got this wetsuit on, you got to run to this next area where your bike is, but what happens? Like, what do they do?
So when we're coming down, you're coming down the river and you had to go to the left. Well, the current's actually kind of strong when you have to swim to the left. So doing that was funny. And then you had to they helped you out of the water, but you had to, just like a ladder, it wasn't just getting out of the water because it's like a pier. So you had to lift out of the water, and you run up a little bit. And if you're wearing a wetsuit, there's wetsuit peelers. So you lay down and they just rip your wetsuit off and give it back to you really quick. Because if you've ever worn a wetsuit, it's really, if you haven't, I mean, it gets really stuck to you, and people are it is a race. Some people take their time, but there's a lot of people trying to at least keep moving forward as quickly as they can. But yeah, so did that, I dried off, changed into my biking gear.
Which was quick. He did that like in 8 or 9 minutes. That's called the transition. So when you change from the swim to the bike, it takes a certain amount of time, and they count that as part of the race. So his was like 8 or 9 minute transition.
Yeah.
That's good.
So I think like that one was like 8 minutes. Another one in my bike to run was like 7.
Yeah, okay.
But like, and that's not great by any standards, but that's fine. I mean, I would say I'm fine with that because I don't practice that, and also the transitions are longer there compared to like a small triathlon like Savannah where it's easy to just get to your bike. You don't have to run through a massive area.
So then what was the 112-mile bike? Well, actually, it was a 116-mile bike ride.
Then took off the 160-mile bike. First 50 miles were going great. It was still cool because it was only like 8:30 when I started the bike. So I started the bike about an hour in, and the bike was going great. The first 50 miles, I was drinking. Using their Gatorade and water mix. I was eating the food I had some peanut butter and jellies. I started eating some of that stuff slowly. But I was averaging like 20 miles per hour, I think, the first 50 miles. And the hills didn't hurt. My legs were so much more fresh. And then it started to get like by mile like 45 to 50, I really started to feel that started going down to like 19 miles per hour. And like 18. Because some of the hills just start gaining on you. And then doing the second loop, all of that stuff, I was like, wow, I already did this the first time. It felt so much harder the second time. Yeah. But
so tell them, what was the fastest you got going on your bike? Because we have speedometers on the bike. So how fast were you going downhill on some of these hills?
Yeah, so you'd be going, I got up to like 36, 37 miles per hour on a long downhill. Yeah. But that's super fun. I'm not even pedaling. I'm just sitting like the aero position. So sitting forward, trying to be aerodynamic. Going up the hills though, you might be going like 8 miles per hour, and I tell you, by the end, you can tell some people are feeling a little defeated.
I saw people. We were waiting for him to come up from his bike, and we were watching these people come up, and I mean, they're just, you can tell they're not running anymore. They're walking up to the changing area, and people were tired.
Yeah, so
it was hot out.
But yeah, so it started getting really hot. I got to like 85 or 90 degrees and sunny. And I was drinking so much water and Gatorade and eating. And
but you did good. You 7-hour bike ride.
No, I know, but I started. I could start feeling that second half of that bike, my exertion level, because I'm working harder and I've been going longer, and I could start feeling myself feel a little bit less. Like I started getting, the heat. I could start feeling that infecting my stomach. But the bike overall and everything there was good. And, I was at 8 hours through the swim and transition 1, the bike and transition 2. So I did 116 miles in 7 hours. And
so then you had the marathon left. So 26 miles to go.
Yeah. So I was sitting there and I was wondering I couldn't wait to get off the bike because your back starts to hurt a ton. And I had stopped a couple of times to go to the bathroom and stretch my back like for a couple minutes. But yeah, by that time, and I knew where we live, it's very flat. So the elevation gain was like 5,500 feet total. So my legs were definitely a lot more, I could feel my quads were a lot more sore. So I seen how the run was going to be, especially doing uphills on the run. And I could tell my stomach had, by the time I transitioned, I ran like the first mile or two, I could start feeling like I was slightly heat exhausted, and I did not want to eat food or drink stuff. I was forcing myself to. But I had to start slowing down. The run is where I really had to test my mental. It was the hardest thing I've done so far in my life race-wise, in terms of all the other stuff. Even when I did a 50-mile run, like 10 and a half hours, I felt like pretty good the entire time and consistent. My body, I could push myself harder, but I knew that wasn't sustainable for 26 miles. And I didn't want to injure myself or risk not finishing the race by pushing too hard. And then,
which was the smart thing to do.
Yeah, because I felt like, I started feeling like I was going to puke and everything else. And on it, if you puke, then that's 10 times worse. You're dehydrated even worse. But yeah, you have to just adjust your, you always have time goals and stuff, but you have to just adjust yourself and enjoy the fact that you get to be out there. Something I always think about, you don't have any headphones or anything. So something I always think about is just having the gratitude that you're able to move. A lot of people would love to be able to move and freely. So, and that's the whole reason you do a race. You want to test yourself. You want to see, you start getting once things aren't going as well, like the bike, yeah, my back hurt and stuff, but those first 8 hours were fine. Even the first 9 hours, it's just when I know I still have to go 4 or 5 hours, I still have 20 plus miles. You really have to start breaking it down just 1 mile at a time, one step at a time, focusing on that. And you have to get the negative. I think it's true for anything in your life. You have to get the negative thoughts out of your head. It's so quickly to start being like, why the heck am I out here? What were you thinking? What are you doing? Yeah. This person's passing me. This is going on. Or you start thinking about that, and you have to quickly. It keeps coming back, but it's a constant back. I think that's just daily life too. It's a good. It gets you into a deeper place like that, but you have to think positively. I can go. If you can go one more step, I can go 10 more steps. And yeah, just really positive self-talk is massive when you're out there for 12 to 15 hours and it's just you and your thoughts. I sing some songs in my head sometimes when people come by, their supporters encouraging you. So always thanking all the supporters and volunteers. other people. There's a shared camaraderie and misery, and these events when I'm other people. I remember like seeing some of the hills together. We're like, oh yes, another hill. And a lot of walking, just be like pace walking up the hills. Because I tell you, it's easy. It's very easy to walk or run a pace of, I can run as quick as like a 6 minute plus mile, just a couple miles. But by that time, I'm having. It started out at 11-minute miles, 12-minute miles, some uphill miles. It's like a 15, 16, 17, 18-minute mile, and it's still for other people. They're like, "Oh, it seems like you're going so slow," but it's hard. It's your body is very sore. But yeah, just getting finished. Yeah, encouraging other people and then getting encouragement. You kind of just find a way to keep going. But I thought it was a great experience because then at a certain point, I always think once you're done, you're done. You just have to suffer that day, and once you're done, you've done that now. The next day will come no matter what, and then.
Well, somebody asked you here. It said, Kevin, did your legs hurt after the triathlon? How many days of rest did you need afterwards?
Yeah, so the night of, my legs definitely were very sore, and my body, like once I was done, my body was very hot. So when I took a shower, my body was like shit. Definitely like needed to readjust. But after I slept that night, I felt way better. Even the next day, like I could walk pretty fine. But really after 2 days, I felt my legs felt they were still heavy, but they felt I could walk normally. And then about 3 days after, I went for like a 30-minute, like just nice and easy run. And then now it's like 6 days after, and my body feels, obviously there's still slight soreness, but overall it feels pretty good because it's too, you're really sore, but I had built up a lot of training. So my body's somewhat used to it.
Yeah. It's weird too, because you start in the dark and then you finish in the dark, that day. It's just a long day.
And you have to put out, I think it's nice sometimes, you have to completely put out, you can't think about what anyone's doing on a normal Sunday. Like I watch football and stuff. You can't think about that. Like you don't think about any of that. Because then it's way worse. Or you can't think about trying. You have to just have your whole day focus on that. Like that's your only objective that day because you're not going to be doing anything after. I knew it would be late anyway, so I knew we weren't going to get dinner or anything. I was just going to eat whatever I could.
Well, we had dinner. But...
Yeah, but like right after, I did not feel like eating at all. I didn't want my stomach. There was multiple times I had to stop. Like my stomach was just, I had to stop. I had bad abdominal cramps. But yeah, it's a great experience to have the first one, and it just shows you can do hard things, and just the importance of training even more. And I think just the biggest thing is getting one under your belt, and I think it's fun to try different things. All right. But all right, guys. That's the end of the episode.
Yeah, we'll end on that. But thanks for watching, and that's our Saturday episode for today. And then we'll see you next Saturday.
Yep. Have a good one. Bye.
Bye.